Okay, so let's continue. Let's continue with the rest of it. So this was as important questions that we have done. Okay. All right, let's go on to the next section over here, and that is, what do you understand by osmotic pressure? Right? Let's see, what do you understand by osmotic pressure? Now, as far as osmotic pressure is concerned, what do you understand by osmotic pressure? Now, osmotic pressure is also related to osmolality. Osmotic pressure is also related to osmolality. And how is that related? Let's see this. Now, 1 milliosmole of a solute, 1 milliosmole of a solute exerts an osmotic pressure. 1 milliosmole of a solute exerts an osmotic pressure of 19.3 millimeters of mercury. 1 milliosmole of a solute exerts an osmotic pressure of 19.3 millimeters of mercury. So that means, what is the osmotic pressure of plasma? What is the osmotic pressure of plasma? This will be, if I first just let's discuss what is the formula for osmotic pressure. Now, osmotic pressure would be number of milliosmoles. Number of milliosmoles of solute, number of milliosmoles of solute per liter into 19.3. Why into 19.3? Because I've just told you that 1 milliosmole of any solute will exert an osmotic pressure of 19.3. And number of, so what, how do you calculate the osmotic pressure in millimeters of mercury? This will be number of milliosmoles of solute in 1 liter into 19.3 into what is known as the osmotic coefficient. Osmotic coefficient is different for different substances, right? Osmotic coefficient is different for different substances. Osmotic coefficient is usually between, this is between 0 and 1. Between 0 and 1. 0 is for a freely permeable substance. A freely permeable substance will have an osmotic coefficient of 0. A freely permeable substance will have an osmotic coefficient of 0. What are freely permeable substances? For example, alcohols. Alcohols are freely permeable. Urea is also freely permeable. It is a slowly permeating substance, but this is freely permeable, right? And what is the osmotic coefficient of 1? This is for an impermeable substance. An impermeable substance will have an osmotic coefficient. Impermeable substance will have an osmotic coefficient of 1, right? So this is how you're going to see the osmotic pressure. What is osmotic pressure in millimeters of mercury? This is number of milliosmoles of solute per liter into 19.3 into osmotic coefficient. And osmotic coefficient is between 0 and 1. 0 is for freely permeable substances. 1 is for an impermeable substance. And osmotic coefficient, like I said, is between 0 and 1. It could be 0.7, 0.8, depending on the permeability of that substance. Now, my next important question over here is, what is the osmotic pressure of plasma? What is the osmotic pressure of plasma? Yes, osmotic pressure exerted by plasma. Is it 3,500 millimeters of mercury? Is it 4,500 millimeters of mercury? 5,500 or 6,500 millimeters of mercury. What is the osmotic pressure of plasma, right? Osmotic pressure of plasma, right? Osmotic pressure of plasma will be number of milliosmoles of solute in plasma, which we've already discussed. That is the plasma osmolality. That is 290. 290 into 19.3 into osmotic coefficient of plasma is taken as 1. right? So this gives me almost 5,500. If you sort of solve this, this is 5,597. So my best answer is 5,500 millimeters of mercury, right? 290 into 19.3, and osmotic coefficient for plasma is taken as 1. Yes. Please remember, osmotic coefficient for different substances is different. It is between 0 and 1. 0 is for freely permeable substances. That means, in other words, freely permeable substances like alcohol, urea do not exert an osmotic pressure. They do not contribute to osmotic pressure. Whereas impermeable substances have osmotic pressure of 1. What is the osmotic pressure of plasma? This is going to be 5,500 millimeters of mercury. Now comes the important part, and that is how much is the colloid osmotic pressure? How much is the colloid osmotic pressure? How much is the colloid osmotic pressure? What is colloid osmotic pressure? Colloid osmotic pressure is also taken as the oncotic pressure. Colloid osmotic pressure or the oncotic pressure, right? What is colloid osmotic pressure? This is the pressure exerted by the colloids in plasma, right? This is the pressure exerted by the colloids in plasma. Which are the colloids in plasma? Proteins, right? Colloid osmotic pressure or oncotic pressure. This is the osmotic pressure due to proteins, due to the colloids in plasma or due to proteins. This is the colloid osmotic pressure. How much is the colloid osmotic pressure? Colloid osmotic pressure varies between 25 to 28 millimeters of mercury. 25 to 28 millimeters of mercury. Okay? Ajay Kumar Reddy, Gitanshi, it is taken as 1. It is given as 1. The standard for plasma is 1. Plasma is by and large impermeable, isn't it? Plasma does not move out. Yes, components of plasma may move across the cell membranes, but not plasma as a whole. So it is taken as 1. But every constituent of plasma will have a different osmotic coefficient. Okay? Gitanshi and somebody else. All right. So 25 to 28 millimeters of mercury. So my next question over here is, which protein contributes maximum to colloid osmotic pressure? Which protein contributes maximum to colloid osmotic pressure? A, is it going to be albumin, globulin, fibrinogen, prothrombin? So the answer here is going to be, the answer here is albumin. Albumin will contribute the maximum to colloid osmotic pressure because albumin is the most abundant protein, isn't it? So this is your albumin is contributing. Albumin is contributed maximum to colloid osmotic pressure. If I ask you what is contributing maximum to osmotic pressure of plasma, then the answer is sodium. But colloid osmotic pressure, which is due to proteins, which protein contributes the maximum? Albumin, right? So this is albumin. So here is another question. Oh, that is Pranisha. Very good point. You said, why is it 38? Why is it 25 to 28? Why not 38.6? Because the third factor, which you have not taken into consideration, Pranisha, is osmotic coefficient. Yes. What is the colloid osmotic pressure? 2 milliosmoles into 19.3 into an osmotic coefficient for proteins is given as 0.7. Some books say 0.8, some say 0.7. Have you understood? Pranisha. Safia, Pranisha, have you all understood this? Osmotic coefficient you did not take into consideration. For proteins, osmotic coefficient is 0.7. Some books have said 0.8 as well. Okay? All right. So now, next important point, and that is which protein contributes maximum to colloid osmotic pressure? And the answer is albumin. Albumin contributes the maximum. So my next question is, why does albumin contribute the maximum? Yes, Gayatri, absolutely right. Colloid osmotic pressure is a part of the total plasma osmotic pressure. Why albumin? A, is it because it has, why does albumin contribute maximum to colloid osmotic pressure? High concentration and a high molecular weight. Please remember, in this particular question, we are comparing the proteins. High concentration, high molecular weight. Is it because albumin is in a low concentration and it has a low molecular weight out of all proteins? Or C, is it because it has a high concentration and a low molecular weight? Or is it because it has a low concentration and a high molecular weight? Please remember, it is out of all the proteins, because we are talking of colloid osmotic pressure. And colloid osmotic pressure means I need to compare all the proteins. Yes? The answer is absolutely right. Prakash Trivedi has answered it. So many of you have answered it correctly. High concentration and low molecular weight. Even though molecular weight is in thousands, but it is considered a low molecular weight out of all proteins. Here we are comparing all the proteins. So albumin is contributing the maximum because the concentration is highest out of all the proteins and the molecular weight is the least. Okay, so we've got this concept. Okay. Please remember, what is osmotic pressure? Let's have a look at this. What is osmotic pressure? This is the related to osmolality. 1 milliosmol of solute exerts an osmotic pressure of 19.3. Osmotic pressure, to calculate number of milliosmoles of solute into 19.3 into osmotic coefficient. Right? And like I said, osmotic coefficient is variable between 0 and 1. Remember, freely permeable substances have osmotic coefficient of 0. Right? Like, for instance, alcohols, urea. Osmotic pressure of plasma. This is 290 into 19.3 into 1. For colloid osmotic pressure, only the proteins will be taken into consideration. And which protein contributes the maximum? Albumin. Why albumin? Because it is the highest concentration and the least molecular weight out of all proteins. What has molecular weight got to do with it, Akshita Makkar? This is because molecular weight will determine the number of osmoles. We've discussed that. How do you convert a protein from grams to moles and osmoles? Divide by the molecular weight. Higher the molecular weight, less the number of moles and osmoles. Okay? Okay. Sarvajit, osmotic coefficient of plasma is 1 is a factual thing. There's nothing more to it. It is a factual thing. Osmotic coefficient is 1. Okay, chalo. So we've all got this concept. Now, where are we going to use the colloid? Now, a very important clinical point here. Let me see if you can correlate it. And I think the regular students does not. Rahul Vasawa, like I said, it doesn't exert any osmotic pressure, right? So yes, that is true. So then it's got a very important clinical point. A patient of uremia, patient of diabetes mellitus or hyperglycemia and uremia both have got a elevated. A patient of hyperglycemia and uremia, they both have an increase in plasma osmolality. Do you agree with me? Yes? Both will show you, if glucose levels are elevated or urea levels are elevated, both will show an increase in plasma osmolality. But a patient of uremia, but thirst is not a common feature. But thirst is not a common symptom. It is not a common feature. In uremia, thirst is not a common symptom in uremia. Both hyperglycemia and uremia, there is an increase in osmolality, but thirst is not a common feature in uremia. Today, now you can explain why. Because what is going to happen to urea? Urea is a slowly permeating substance. Urea is a slowly permeating substance. It has an osmotic coefficient of 0. It can move across the cell membranes. So it moves across the membranes of the osmoreceptors and does not stimulate them. Remember, how do osmoreceptors get stimulated? Once the ECF osmolality is elevated and these osmoreceptors shrink. But here in uremia, what is happening is urea can cross the cell membranes. So it is a slowly permeating substance. So it does not stimulate the osmoreceptors. So thirst is not a common feature. Go back to your medicine and you realize in a patient of uremia, thirst is not a common feature. Diabetes, thirst is going to be a common feature. Okay? All right. Oh God, what a long question. What is this? Could you explain the calculation of colloid osmotic pressure? Oh, okay. Shilpa Chandran. Colloid osmotic pressure is 2 milliosmoles into 19.3 into osmotic. Number of milliosmoles of proteins. Number of milliosmoles into 19.3 into osmotic coefficient. That is how you're going to calculate the colloid osmotic pressure. Yes, this is the formula for colloid osmotic pressure. Number of milliosmoles into 19.3 into the osmotic coefficient. Okay? Okay. Naman Agarwal, osmotic coefficient is 0. Kiska 0 hai beta? Naman Agarwal? What are you getting confused with? See, what happens in uremia is, why is urea not contributing to thirst? Even though urea will increase the, it's a solute in plasma, so it will increase, in the patient of uremia, there will be increase in plasma osmolality. But thirst is not common in uremia because urea is a slowly permeating substance. It can move across the cell membranes, right? Yes, it is freely permeating, but slowly. It is freely permeating, but slowly. Oh God, so many of these doubts are not able. Cross membranes, hence osmoreceptors are not stimulated. Anup John is absolutely right. Diffuse, no change in osmolality. Yes, okay. Okay, fine. Now, this is as far as your slowly permeating. Now, the next important point which I need to discuss is the application of colloid osmotic pressure. And that is known as the Starling's forces in a tissue capillary. Starling's forces in a tissue capillary. Right? Let's see this. Where do we apply? Starling's forces in a tissue capillary. Okay? Now, when you look at a tissue capillary, there are two important forces which act in a tissue capillary, and that is a push force. There is a push force and there is a pull force. In a tissue capillary, there is going to be a push force. Now, what is the push force? Push force is hydrostatic pressure. Hydrostatic pressure. H in push, H in hydrostatic. Okay? Hydrostatic pressure. Push force is hydrostatic pressure. What is hydrostatic pressure? Hydrostatic pressure means pressure due to a column of liquid. This is what pushes the fluid out of the capillary into the interstitial space. That is a push force. What is the pull force? Pull force is the colloid osmotic pressure. Double L in colloid, double L in pull. So you have a push force and you have a pull force. A push force will push the water out of the capillary into the interstitial space. Pull force will pull the fluid back. So here you have PC and pi C. What is PC? PC is the capillary hydrostatic pressure. PC is the capillary hydrostatic pressure. Capillary hydrostatic pressure. And what is pi C? Pi C is the capillary colloid osmotic pressure. So you have a push force and a pull force. Now, similarly, the interstitial fluid also has a push force and it has a pull force. Now, push force will push the fluid from the interstitium into the capillary. Pull force will pull it back towards itself. So what is the push force here? Push force is Pi and pull force is pi I. What is Pi? Pi is the interstitial fluid hydrostatic pressure. Pi I is the interstitial fluid colloid osmotic pressure. Interstitial fluid colloid osmotic pressure. So this is your push forces, pull forces. Please appreciate the direction of the arrows. PC is the capillary hydrostatic pressure. It will push the fluid out of the capillary into the interstitial space. Pi C. Pi C is the colloid osmotic pressure, which will pull the fluid back into the capillary. Pi is the interstitial fluid hydrostatic pressure, which will push the fluid from the interstitium into the capillary, and pi I will pull the fluid back into the interstitium. Please remember here, this is PC is the largest force. PC is the largest force. So what is going to be the net pressure? What is the net pressure? If PC is positive, pi C is opposing PC, so it becomes negative. PC minus pi C minus Pi plus pi I. PC minus pi C minus Pi. Why Pi is minus? Because it is opposing PC. Opposite, the direction of Pi is opposite to PC. So minus Pi plus pi I. This is PC minus pi C minus Pi plus pi I. This is your net pressure. Now let us see what is the normal. PC is 35 millimeters of mercury. Pi C is 25 millimeters of mercury. Pi is minus 1 millimeter of mercury. Why is it minus 1? This is because of a continuous drainage into the lymphatics. Continuous drainage into the lymphatics. Right? Minus 1. Pi I is 0. What is pi I is 0? This is because of no proteins, because there are no proteins in plasma. Right? No proteins in plasma. So normally the pi I is 0. So this is PC is 35, pi C is 25. Pi is normally a minus 1. The interstitial fluid hydrostatic pressure is not a positive force, it's in fact a negative force, normally. And this is because of the continuous drainage into the lymphatics, and pi I is 0. Yes? So what is going to be the net pressure? Net pressure is PC minus pi C minus Pi plus pi I. So this is going to be 35 minus 25 minus minus 1 plus 0, or which is plus 11 millimeters of mercury. This is the net force which is acting. Positive sign means that there is net movement of fluid from the capillaries into the interstitium, and whatever fluid comes into the interstitium will be drained by the lymphatics. This is what it means. This is what happens normally. The direction of the net force, is, like I said, direction of the net force is from the capillaries into the interstitium, right? So pi I is, like I said, net force is plus 11 millimeters of mercury. Now, this is what is your Starling's forces acting at the tissue level. Remember, any fluid will have a push force and a pull force. Push force is hydrostatic. Hydrostatic means pressure due to a column of liquid. Pull force is colloid osmotic. It pulls the fluid back into the capillary. Similarly, interstitial fluid also has a push and a pull force. Any fluid will have a push and a pull force. Push force of the interstitium will be directed towards the capillary, and pull force will be directed from the interstitium towards the capillary. Pull force will be towards the interstitium of, like I said, pi I. Remember the direction of the arrows, and then to decide what is the net pressure does not. Now, as far as there was a question which had come in AIMS, which was related to this. Let's have a look at that question. Now, the question said that this was an AIMS question. It said that PC, capillary hydrostatic pressure, is 25 millimeters of mercury. Pi C we do not know. Interstitial fluid hydrostatic pressure, this was, like I said, an AIMS 2015 question. Okay. PI, the interstitial fluid hydrostatic pressure, this is normally -1, but now it is given to you as 2 millimeters of mercury. Pi I, which is 0, is given to you here as 7 millimeters of mercury. That means some problem here. Maybe there are now proteins present in the interstitium. Net pressure was given to you as 3 millimeters of mercury. You had to find out the capillary hydrostatic, the capillary colloid osmotic pressure. You have to find out the capillary colloid osmotic pressure. Okay? So what is it going to be? We know the formula. Net pressure. Net pressure is PC minus pi C minus PI plus pi I. PC here is given as 25. This is 3 minus 25. Now PI is given as a plus force. Sorry, this is given as a plus 2 and this is plus 7. Right? So what is going to be the answer here? 25 minus, sorry. So pi C is equal to 27 millimeters of mercury. Okay? Please remember the formula. The net pressure is PC minus pi C minus PI plus pi I. If PI is given as a negative force, substitute as a negative force, -1, like I told you, normal value. In this question, PI is given as a plus force, +2. So substitute PI as +2 and you will get the answer accordingly. Right? Whatever the value, substitute that in the formula, you will get your answer. Right? So remember, net pressure is PC minus pi C minus PI plus pi I. Right? PC minus pi C minus PI plus pi I. Now, okay. Now, the rate of tissue fluid formation, rate of tissue fluid formation. Rate of tissue fluid formation. This is directly proportional to the net pressure. This is directly proportional to the net pressure. This is directly proportional to PC minus pi c minus pi plus pi I. If I want to remove the proportionality sign, bring an equal to sign, I have to multiply it by a constant. And that constant is Kf into Pc minus pi c minus pi plus pi I. And what is Kf? And what is Kf? Kf is your ultrafiltration constant. This is the ultrafiltration constant. Ultrafiltration constant, right? Now, ultrafiltration constant, and this is permeability into surface area. Permeability into surface. What is Kf? This is permeability into surface area. So rate of tissue fluid formation will be directly proportional to the net pressure. And when I want to remove the proportionality sign, I will have to bring an equal to sign, and that means I have to multiply. If I want to equal to sign, I have to multiply it with via constant, and that constant is ultrafiltration constant, which is permeability into the surface area. Right? So that means what are the factors which affect the rate of tissue fluid formation? Let's try and see that. Number one, capillary permeability. Number two, surface area. More the surface area, more the tissue fluid formation. Number three, PC, pi c, pi, pi I. These are 6 factors which affect the rate of tissue fluid formation. Right? Rate of tissue fluid formation. This is your capillary permeability, for example, inflammation. In inflammation, what happens to capillary permeability? Increases. Tissue fluid formation increases. Right? So surface area, more the surface area, more the tissue fluid formation. More the hydrostatic pressure, more the tissue fluid formation. Right? Like for instance, let's take some clinical applications of this. Clinical applications. You have a patient of right heart failure. Patient of right heart failure. Because of back pressure, now the right heart is not pumping properly. So there is back pressure. Because of back pressure, there is increase in the capillary hydrostatic pressure, especially in the lower limbs. Especially in the lower limbs in an ambulant patient. There is increase in capillary hydrostatic pressure. So if there is increase in, what is capillary hydrostatic pressure? Push force. So it pushes the fluid out of the capillaries into the interstitial space. So there is going to be increase in, what happened? Where it has the screen gone? 1 second. One second. वन नोट वाला स्क्रीन देखो, वो नहीं आ रहा है. All right, so like I said, right heart failure, what is going to happen now? Because of the back pressure, because the heart is not pumping blood properly. So what happens is there is back pressure now causes increase in the capillary hydrostatic pressure. Capillary hydrostatic pressure, and capillary hydrostatic pressure means there is going to be increase in the push force, and increase in push force means what is going to happen to the tissue fluid formation? There is an increase in the tissue fluid formation. Right? There is an increase in the tissue fluid formation. So edema, isn't it? Pedal edema is such a common problem in a patient of right heart failure. Pedal edema or sacral edema in the case of a bedridden patient, but pedal edema in an ambulant patient. Right? Okay. Okay, all right. So this is right heart failure. Like I said, because of back pressure, increase in capillary hydrostatic pressure. And this is the okay. All right. Let's go on to another application of the whole thing, and that is just sorting out that problem. We're just sorting out that problem. Sorting out that problem, yeah. Sorting it out, sorting it out. Yes. Sorting it out. Just wait, hang on for a second. Hang on for a second. We're trying to sort out this problem. Okay. Just 1 second, please. 1 second. It is not a simple question of minimizing. There are two laptops which are functioning at the same time. बस 2 मिनट 1 मिनट रुक जाओ आ गया okay fine that's it I don't have to look at my own face now. All right, so ठीक है. So what happens in the case of a right heart failure? Like I said, this is because the heart is not pumping blood properly. There is going to be a back pressure, and back pressure will cause an increase in the hydrostatic pressure, especially in the lower limbs, and that in turn results in a increased tissue fluid formation, and edema is very commonly seen. Same reason. What happens in a left heart failure? Pulmonary edema. Same thing. Back pressure now in the pulmonary capillaries will increase the hydrostatic pressure of the pulmonary capillaries, therefore pulmonary edema. Right? Now, this is what happens in the case of right heart failure. Let's see what happens in a patient of liver cirrhosis. Let's see what happens in a patient of liver cirrhosis or nephrotic syndrome. Liver cirrhosis or nephrotic syndrome. In liver cirrhosis or nephrotic syndrome, these are both conditions of hyponatremia. These are both conditions which will result in hypoalbuminemia. And hypoalbuminemia means what will happen to the colloid osmotic pressure? Colloid osmotic pressure will now decrease. And if there is a decrease in the colloid osmotic pressure, there is a decrease in the pull force. Again, there is an increase in the tissue fluid formation. Right? Tissue fluid formation. So again, edema, isn't it? Both these conditions, cirrhosis, nephrotic syndrome, hypoalbuminemia, is associated with anasarca, isn't it? Because of hypoalbuminemia reducing the colloid osmotic pressure, which in turn increases the tissue fluid formation, resulting in edema. Right? So this is, please remember. Yeah, please remember so this is your Starling's forces. So just a quick revision. Starling's forces, please remember there is a push force, which is the hydrostatic force, and a pull force. Hydrostatic force is pressure due to a column of liquid. Hydrostatic. Capillary hydrostatic pressure will push the fluid from the capillary into the interstitial space. Interstitial fluid hydrostatic pressure will push the fluid from the interstitium to the capillary. So this is the push force. PC, appreciate the direction of arrows. PC will push the fluid from the capillary into the interstitial space. PI will push it back. Pi C is the colloid osmotic pressure in the capillary, which will pull the fluid back into the capillary. Pi I will pull the fluid towards the interstitium. So direction of arrows, appreciate the direction of arrows. So PC is the largest force. This is taken as positive. Pi C opposes PC, so minus. Pi opposes PC, so minus. Pi I is in the same direction as PC, so plus. Net force is PC minus pi C minus Pi plus Pi I. I gave you the normal values, and then I gave you also an Ames question which was asked, and a lot of people are saying we don't have pen and paper, we don't have, these are simple calculations, simple plus and minus, which you are expected to do. Don't ask me why such questions are given. Numerical based questions are a reality. They are asked in the Central Institute exams. This is, now Jitendra, you can repeatedly asking why sodium has no role in pull force. You must understand that the plasma and the interstitial fluid, the osmolality is the same, is nearly the same. The only difference are the proteins in the plasma. So proteins are present in plasma, but not in the interstitial fluid. So the pull force will only be that pressure exerted by the proteins, which is the colloid osmotic pressure. Have you understood? I'm not taking the osmotic pressure of plasma into consideration, because osmotic pressure of plasma and interstitial fluid is nearly the same. Plasma is slightly higher by 2 milliosmoles because of presence of proteins. So the osmotic pressure because of proteins is taken as the pull force. Have you understood? And that is 2 milliosmoles. All right, so this is as far as your pi I is normally 0, physiologically 0, but in certain conditions, like I gave you this Ames question, here the pi I was 7. That means proteins were present even in the interstitial fluid. Have you understood? Okay, all right. Yes, absolutely right, Snehal. This is the, in case of cardiac failure, it first starts in ambulant patients, pedal edema, and then moves upwards, whereas in the case of renal failure, because hypoalbuminemia, that is the reason for edema and renal failure. In patients of cardiac failure, it is because of the hydrostatic pressure. Pathology is different in both the cases. All right, now 2-3 important questions here, and that is organ with maximum KF, organ with maximum PC, this is going to be kidney. Organ with maximum PC is the kidney. The hydrostatic pressure in the glomerular capillaries is 45 millimeters of mercury. 45 millimeters of mercury. Most capillaries is 35, but in glomerular capillaries, it is 45 millimeters of mercury. Then organ with maximum KF. KF was ultrafiltration constant, which is permeability into surface area. This is also the kidney. And which is the organ with maximum capillary permeability? Which is the organ with maximum capillary permeability? Is it going to be the kidney or is it going to be the liver? Please remember, if the question says maximum KF, it is the kidney. What is KF? Permeability into surface area. But if it only talks about permeability, then it has to be the liver. In the kidney, the capillaries are fenestrated. Fenestrated capillaries. Fenestrated means it is like a sieve. There are gaps, there are sort of pores which are present. But the liver, the capillaries are sinusoidal. Sinusoidal. Sinusoidal means there are large gaps which are present between the endothelial cells. So organ with maximum capillary permeability will be liver, but maximum KF is going to be the kidney, because kidney is permeability and surface area, right? So these are three important questions. PGC, GC is glomerular capillaries. Hydrostatic pressure in glomerular capillaries. GC is glomerular capillary. Glomerular capillaries are in kidney. Okay? Okay, let's go on to the next section in this chapter. And before I take on the next section, let's answer a few questions. Okay, let's see for a few questions. We've already done this. Let's see this question here. 1 gram of mannitol. 1 gram of mannitol was injected into a patient. After equilibration, a plasma sample had a mannitol concentration of 0.08 grams. During equilibration, 20% of the injected mannitol was excreted. What was the patient's ECF volume? Now, we have already done that. Formula is V is equal to, formula here is V is equal to Q minus E over C. Q has been given. Q is 1 gram, that is 1000 milligrams. E is given. E is 20%, which is 200 milligrams. So that means 800 milligrams divided by 0.08 grams per liter. We need to convert this into milligrams per ml. Milligrams per ml. So this will be again 0.08 milligram per ml. Yes? All right. Okay, great. Same formula, V is equal to Q minus E over C. Okay. Let's see the next one. We've already done this, X, Y, Z. What is the osmolality? Let's see this question, right? What is the osmolality of a solution containing 10 millimoles of NaCl, 5 millimoles of KCl, and 10 millimoles of CaCl2. Again, a revision. How do you convert millimole to milliosmol? Multiply by the number of freely moving particles. So 10 millimoles of NaCl will be 20 milliosmoles of NaCl. 5 millimoles of KCl will be 10 millimoles of KCl. 20 millimoles of CaCl2 will be 30 milliosmoles of CaCl2. Please remember, how do you convert a mole into osmol? Multiply by the number of freely moving particles liberated by that substance in solution. So 20 plus 10 plus 30 will be 60 milliosmoles per liter. Absolutely right. This is basically to test whether you remember how to convert moles into osmoles. Let's see this. Let's see if you can answer this question now. This says, which of the following is likely to happen if RBCs with an intracellular osmolality, with an intracellular osmolality of 280 milliosmoles are placed in a solution. RBCs are placed in a solution. RBCs have an intracellular osmolality of 280. Outside solution is 140 millimoles of NaCl and 20 millimoles of urea. 140 millimoles of NaCl and 20 millimoles of urea. So that means outside osmolality will be 280 plus 20, which is 300 milliosmoles. Outside is 300, inside is 280. Outside is higher as compared to inside. Cells will definitely shrink. Cells will definitely shrink, but the catch here is urea. Urea is a slowly permeating substance. Urea will move from outside to inside. This is slowly permeating. It will move from outside to inside. Water will follow. So cells which had shrunk will now return to original volume. Right? Please understand this once again. Inside osmolality is 280. Inside the cells, the osmolality was 280. Outside is 280 plus 20. 280 because of sodium chloride, 20 because of urea. So outside osmolality is 300, higher than 280. Cells will tend to shrink, but the catch being outside you have urea, and urea will move from outside to inside the cells. Water will follow. So cells which had originally shrunk will now increase in size and come nearly to. If urea was not in the question, Shivani, cells would have only shrunk. Have you understood? But because urea is there, initially they will shrink and then they will increase in size. Have you understood? Right? So this is, see, remember, urea is a slowly permeating substance. So urea is what is known as an ineffective osmole. Why do I call it ineffective osmole? Why is it ineffective? Because it is moving from one compartment to the other, isn't it? It is moving from one compartment to the other, right? Why is when moving anything which is it's a dal badlu, isn't it? What is a dal badlu? People in the north will understand, right? A neta who goes from one dal to the other, one party to the other, dal ineffective. Similarly, urea goes from one compartment to the other, ineffective. Have you understood? That is again correlate with what I told you earlier. Patient of uremia, no thirst. Have you understood? This is an ineffective osmole. Okay? Outside is not 140 plus 20 beta. Please look at this. Millimoles में 140 है, milliosmoles में 280 हो जाता है. इससे पहले वाला क्वेश्चन हमने यही तो किया था. ठीक है? Deepthi Anil Kumar, please, you are making a mistake. It is given in millimoles. You have to convert it into milliosmoles. इससे पहले वाला क्वेश्चन यही तो था. How is extracellular 280? क्या हो गया? Hypoglycemia. Okay. If urea is not, no change, right? Same osmolality. Obviously, Swadha, क्या problem है उसमें बेटा? देखो बेटा, जब भी water कहाँ से कहाँ जाएगा? From an area of lower osmolality to an area of higher osmolality. जहाँ पर water ज़्यादा है to an area जहाँ water कम है, right? From an area of lower osmolality means water ज़्यादा है, dilute solution है. Higher osmolality means water कम है. So water will move from dilute to concentrated, lower osmolality to higher osmolality. Okay, all right. Next, let's see this. Compared with ECF, the ICF has sodium ion concentration lower or higher. Compared with ICF, ECF has higher sodium, lower potassium, higher chloride, lower phosphate. So my answer is C. Right? Answer is C. Okay? So there is a higher sodium, lower potassium, more chloride, and lower phosphate. Okay. Let's see the next one. Net filtration pressure. Net filtration pressure should not be a problem. This is PC minus pi C minus Pi plus pi I. PC here is given as 42. Pi C is given as 12. This is given as 16 and this is 0. Isn't it? No proteins are filtered. Now in this case, it is of course for kidney, right? So PC here is PGC, glomerular capillary hydrostatic pressure. Pi C is pi GC. Pi here is Bowman's capsule and pi I is Bowman's capsule, right? So 42 minus 12 minus 16. So this is going to be 14 millimeters of mercury, right? 14 millimeters of mercury. Okay, let's have a look at the next question. This also you should not have a problem. Again, this is PC, KF, rate of tissue fluid formation is KF into PC minus pi C minus PI plus pi I. KF is given as 0.5, PC is given as 30, pi C is 25, PI is minus 2, and this is plus 2. Okay? So this is 0.5 into 5 plus 2, 7 plus 2, 9. So 4.5. Okay? This is your 4.5 ml per minute. ml per minute. This is going to be the answer. Okay? Remember, KF into PC minus pi C minus PI plus pi I. All right. Let's go on to the next thing here. The next, what I'm going to discuss with you here is, okay, the next thing which I'm going to do with you is what is the Darrow-Yanet diagram. Whatever we have learned up till now, we are just going to consolidate this, apply it to clinical situations, the applied part, and how we are going to use it in clinical situations. That is your Darrow-Yanet diagram. Now, what is a Darrow-Yanet diagram? This is also sometimes known as the DY diagram. DY diagram, right? Now, in this case, in the Darrow-Yanet diagram, we use a rectangle to represent the total body water. A rectangle is used to represent the total body water. Volume is represented horizontally and osmolality is represented vertically. Let me answer these two questions. They're repeatedly asking it. CP, you said millimole to osmole. We have to divide or multiply. Please remember, 1 osmole is equal to 1 mole divided by number of freely moving particles, but 1 mole will be 1 osmole into number of freely moving particles. Go back to your notes and see that once again, right? So the answer, yes, George, absolutely right, multiply. Now, mini dar, why colloid osmotic pressure in the Bowman's capsule is 0? Because no proteins are filtered. Normally, no proteins are filtered in the glomerular capillaries. So colloid osmotic pressure in Bowman's capsule is 0. Yes? Okay. If Aishwarya, if KF is not given, do we assume it? No, KF is given. KF is known. It's different for different capillary beds because it depends on 2 factors, permeability and the surface area. So it will be different for different capillary beds. Okay? All right. Now, no more doubts, and please concentrate on Darrow-Yanet diagram. This is something which you don't do in UG, and this is application of whatever you have learned up till now. Now, volume is represented horizontally and osmolality is represented vertically. Now, please remember that out of the total body water, 2/3 is in the ICF and 1/3 is in the ECF, and osmolality normally on both sides is the same, which is your, we've already discussed that, 290 milliosmoles, right? So height of these 2 smaller rectangles is going to be the same, right? The 2 smaller rectangles, volume, 2/3 in the ICF, 1/3 in the ECF. You've already done that. Okay? So this rectangle is representing total body water, 2/3 in the ICF, 1/3 in the ECF, and osmolality of both the ICF and the ECF is the same. So height of the 2 smaller rectangles is the same. Now, what is this importance of the DY diagram? This will tell you what are the changes which are going to happen when you add fluid or if there is loss of fluid from the body, right? So 3 important questions. No, Komal, please see your notes. Osmole formula is not wrong. Okay. What that dy diagram? Now, three basic principles: addition or loss of fluid. Addition or loss of fluid is from the ECF. Addition or loss of fluid is from the ECF. Number two, ECF osmolality. Whenever you add fluid to the body, that means if you give an intravenous fluid, for instance, it will first go to the ECF. Now, ECF osmolality determines the shift of fluid. It determines the shift of fluid. That means, will this shift of fluid will be from ECF to ICF or ICF to ECF? This will be determined by the ECF osmolality. Number three, shift of fluid will occur shift of fluid occurs till ECF and ICF osmolality are same. Shift of fluid will occur till the ECF and ICF osmolality is the same. Right? So addition or loss of fluid. So this is the three basic principles that you have to keep in mind. Three basic principles which we keep in mind: comal and lost shelf. When I take the lunch break, we can refer to your problem and what is the problem in your understanding or in my way of explaining. Okay, comal and the lost shelf. Please concentrate on what is being done. Let's not get lost in irrelevant things right now. So addition or loss of fluid, so three important principles to keep in mind. Addition or loss of fluid is from the ECF. ECF osmolality determines the shift of fluid, and this shift of fluid will occur till the ECF and the ICF osmolality are the same. Okay? So keep these three basic principles in mind. Yes? Now, let's take the first clinical example, and that is supposing I add 500 ml of isotonic saline. So let's see what will happen if there is addition of isotonic saline. Isotonic saline. Right? Supposing there is addition of isotonic saline. So what did I say? This is the normal dy diagram. Total body water, 2/3 ICF, 1/3 ECF. When I add isotonic saline, now there is going to be increase in total body water. Obviously, you've added fluid, but it is the ECF volume which will increase. But there is no change in ECF osmolality. So this is going to be the net result. There is an increase in total body water. There is increase in the ECF volume. ECF osmolality remains unchanged. ICF volume and ICF osmolality, these remain unchanged. Right? So there is going to be no change in either the ICF volume or the ICF osmolality. Whenever you add an isotonic fluid, isotonic saline, any isotonic fluid for that matter, you are increasing the total body water, but you're increasing only the ECF volume. ECF osmolality is there is no change. ICF, therefore there is no shift of water. Remember the second principle I told you? ECF osmolality determines the shift of water. Right? Here there is no shift of water. So this is if you add isotonic saline. Now supposing, let's say, if there is addition of hypotonic saline. If there is addition of hypotonic saline, now what will happen? If there is addition of hypotonic saline, I'm adding a hypotonic fluid. So now what happens? ICF, ECF, right? So there is going to be, obviously you're adding fluid, so there is increase in total body water. There is increase in ECF volume, but what will happen to the ECF osmolality? You've added dilute solution. So ECF osmolality reduces. If ECF osmolality reduces, I've already told you, water will move from dilute to concentrated solution. Water will move from an area where water is more to an area where water is less. So there is now movement of water from ECF to ICF till ECF and ICF osmolality is the same. So what will happen to the net result? There is also an increase in the ICF volume, decrease in ICF osmolality. This is what has happened. This is going to be the final picture, right? There is an increase in ECF volume. There is a decrease in ECF osmolality. There is increase in ICF volume and decrease in ICF osmolality. Absolutely right, Sriraj Alapati. You are able to correlate. This is a dilutional hyponatremia, right? Dilutional hyponatremia. So this is this is what happens if there is addition of hypotonic saline. Yes, there is increase in total body water now, but because there is now a decrease in osmolality, there is shift of water from ECF to ICF, and this is ultimately result in a increase in ECF volume, but decrease in ECF osmolality. Remember, the shift of fluid will be till the osmolality is the same on both sides. Next, let's have a look at addition of hypertonic saline. Addition of hypertonic saline. Addition of hypertonic saline. Now let's see what happens. Again, we've got the ICF, ECF. There will be increase in total body water. Remember now the first principle, addition of fluid will be in the ECF. But now the ECF osmolality will rise. Yes, if it rises, that means water will move from ICF to ECF. So net result will be, though there is going to be increase in total body water, has to be, because you've added water, right? You've added a fluid, but it is a concentrated fluid. So it will cause the cells to shrink, even though the total body water has increased, but the cells will now shrink. Have you understood? There is increase in total body water. There is increase in the ECF volume. Water will move from ICF to ECF. Yes, still the osmolality is same on both sides. There is also an increase in the ECF osmolality. There is a decrease in ICF volume and an increase in ICF osmolality. Yes, it will produce a cellular dehydration. Please remember, even though you are increasing the total body water, you are adding water. You are adding water, but you're still causing the cells to shrink. This is what happens if you add isn't it? A common kind of an example, for instance, you cannot survive on seawater, isn't it? Seawater is hypertonic. You keep consuming seawater, you will increase ECF osmolality and the cells will shrink, right? It is incompatible with life. There is a cellular dehydration, right? Seawater, absolutely right. So this is what will happen if there is hypertonic saline, right? Now the next is, so addition of isotonic, and hypertonic saline. Now let's see what will happen if there is loss of fluid. So let's see if there is loss of isotonic fluids. Let's see if there is loss of isotonic fluids. Loss of isotonic fluids will be seen in a patient of hemorrhage. It will be seen in a patient of burns. In initial stages of diarrhea and vomiting. Initial stages of diarrhea and vomiting, right? So these are the ones, this is loss of fluid. Now let's see, these are loss of isotonic fluids. Again, loss will also be first from the ECF, and ECF osmolality will determine the shift of water, right? So loss of water from the ECF will now reduce the ECF volume. The dotted line is telling you what is going to be the net change. There is no change in the osmolality. Right? So what will happen now? There is a decrease in the ECF volume. ECF osmolality is unchanged because it is loss of isotonic fluids. ICF volume and osmolality. ICF volume and osmolality will both remain the same. This is decrease in ECF volume, decrease in ECF osmolality is unchanged, ICF volume and osmolality remains the same, right? This is as far as your Now, loss of isotonic fluids. Now, if there is loss of hypotonic fluids, that means loss of dilute fluid. This is seen in patients of diabetes insipidus. Loss of hypotonic fluid, this is seen in a patient of diabetes insipidus, or let's say later stages of diarrhea and vomiting. Right? Initial stages of diarrhea and vomiting, the fluid loss is isotonic, but later it becomes hypotonic. Yes? So that means now let's try and see what is going to happen here. Loss of fluid will be from ECF. Yes? Yes, excessive sweating. Absolutely right. Excessive sweating, dehydration. So loss of fluid is from ECF, but this is a dilute fluid. So that means there is more loss of water and less loss of solutes. So what will happen? Even though that the ECF volume reduces, but the ECF osmolality will increase. That means shift of fluid from ICF to ECF till the osmolality is the same on both sides. So what will happen here? If there is loss of hypotonic fluids, there is a reduction in the total body water that you can see by the dotted line. The complete total body water, the volume of total body water has reduced because there is loss of water, loss of fluid. But what has happened to the osmolality? Osmolality has increased. So loss of hypotonic fluids will cause a hyperosmotic dehydration. This will cause a hyperosmotic dehydration. There is a decrease in ECF volume. There is an increase in the ECF osmolality. There is a decrease in the ICF volume, and there is an increase in ICF osmolality. This is what happens in loss of hypotonic fluids. Right? It will produce a hyperosmotic dehydration. Please remember, if it is loss of isotonic fluids, it is producing an isoosmotic dehydration. There is loss of total body water as indicated by the dotted line, but the change is mainly in the ECA volume with no change in osmolality. So it's isoosmotic dehydration. Loss of hypotonic fluids is producing a hyperosmotic dehydration. Increase in osmolality, reduction in the total body water, reduction in both ECF as well as ICF. Now, let's see next is loss of hypertonic fluids. Loss of hypertonic fluids. A typical example of loss of hypertonic fluids is Addison's. In Addison's disease, there is more loss of solutes, less loss of water. So concentrated urine. Addison's means mineralocorticoid deficiency. So loss of hypertonic fluids. ICF, ECF. Now there is going to be decrease in total body water, definitely. Loss will be first from the ECF, but what will happen to ECF? So ECF volume will reduce, but ECF osmolarity will also reduce. Yes? So if ECF osmolarity reduces, water will shift from ECF to ICF till the osmolarity is the same on both sides. So this is what is going to happen. This is your hypoosmotic. There will be a hypoosmotic dehydration. There is loss of total body water. There is decrease in osmolarity. There is a decrease in ECF volume. There is decrease in ECF osmolarity. There is increase in ICF volume and a decrease in ICF osmolarity. Right? So this is going to be loss of hypertonic. Please remember, the only way to understand the DY diagram is keep those three basic principles in mind. Addition or loss of water will be first from the ECF. Whatever the changes in ECF osmolarity will determine the shift of fluid, either from ICF to ECF or ECF to ICF. And number three, shift of fluid will occur till the ECF and the ICF osmolarity is the same. Right? So if you're looking at addition of water, it depends upon what sort of a fluid is added. If it is addition of isotonic fluids, there is increase in total body water with no change in osmolarity. So there is increase in only the ECF volume and therefore increase in total body water. The dotted line shows you the change. If you add hypotonic saline, yes, you are increasing the total body water, but you're also reducing the osmolarity first in the ECF. And because there is reduction in the ECF osmolarity, water will move from dilute to concentrated, from ECF to ICF till the osmolarity is the same on both sides. So net result will be increase in total body water, increase in ECF volume, decrease in ECF osmolarity, increase in ICF volume, decrease in ICF osmolarity. If you look at addition of hypertonic saline, you are adding water, so you're going to increase the total body water. But at the same time, you're also increasing the ECF osmolarity, so shift of water from ICF to ECF, so cellular dehydration, in spite of increase in total body water. Loss of isotonic fluids, there will be shrinkage, there's loss of total body water, decrease in total body water, shrinkage of total body water, but no change in osmolarity. So it's only an isoosmotic dehydration. Loss of hypotonic fluids, decrease in total body water, but increase in osmolarity. So hyperosmotic dehydration. Loss of hypertonic fluids, hypoosmotic dehydration. Loss of hypertonic fluids, hypoosmotic dehydration. Yes? So this is what is going to happen in a patient of whenever there is addition or loss of fluid, right? Now, the next is, let me just discuss one question here with you. Let's see this question. Now, which of the following represents the body fluid compartment in a man lost in a desert? Man lost in a desert has no access to water and there is excessive sweating. So that means this is going to be excessive sweating, and excessive sweating means there is going to be, if there is an excessive sweating, that means loss of hypotonic fluids or a hyperosmotic dehydration. Hyperosmotic dehydration. That means there has to be decrease in total body water and osmolarity must rise. Now this is, remember, dotted line is the change. This is decrease in total body water, but no change in osmolality, तो ये भी नहीं है. B is increase in total body water with no change in osmolality, तो ये भी नहीं है. This is a decrease in total body water and an increase in osmolality. Yes, so this is your hyperosmotic dehydration. Right? So your answer is C. Absolutely right. So everybody has got this. Please remember, if you get a question where you have to identify which Darrow-Yannet diagram, please see, is there an increase in total body water or a decrease? If it is increase, see, is it isotonic, hypertonic fluids? If it is a decrease, see whether is it isoosmotic dehydration, hypoosmotic dehydration, or a hyperosmotic dehydration. Remember, loss of hypotonic fluids will produce hyperosmotic dehydration, like in this question. Loss of hypertonic fluids will produce a hypoosmotic dehydration. Okay? Good. This is as far as your the Darrow-Yannet diagram is concerned. Okay, let's go on to the next section of this chapter. Next is cell membrane and transport across cell membrane. Let's see cell membrane. Now, as far as cell membrane is concerned, a cell membrane is, let's see, what is the thickness of the cell membrane? Thickness of the cell membrane, this is 7.5 nanometers, or it is 75 angstroms. Cell membrane is 7.5 nanometers or 75 angstroms. Cell membrane, if you remember the fluid mosaic model, yes. If you remember, there is a lipid bilayer plus there is the presence of proteins. Lipid bilayer plus the presence of proteins. Right? Lipid bilayer plus the presence of proteins. If you can see, if you remember your diagram of what a cell membrane looks like, cell membrane, if you remember, there is double, this is a lipid bilayer here, lipid bilayer, and they have hydrophilic heads and hydrophobic tails. You do this in biochemistry in detail, right? So these are your hydrophilic heads and hydrophobic tails. This is how it forms a bilayer, yes? And you also have the proteins. Proteins could be integral proteins, they could be peripheral proteins, yes? Or integral proteins or peripheral proteins. So let's see what are the functions of the proteins. Now, as far as these proteins are concerned, these proteins can act as channel proteins. They can act as receptors. These proteins can be transport proteins. Transport proteins, these can act as structural proteins. They can act as antigens, or they can also be enzymes. So these are the different functions of proteins which are present, right? Different functions of proteins which are present. They can be channel proteins, receptor proteins, transport proteins, structural proteins. They can be antigens, they can be enzymes, right? So this is your, now if you look at the lipid bilayer and proteins, now most cell membranes, in most cell membranes, now there was a question which was asked, and this says, in terms of dry weight of a cell membrane, in terms of dry weight of a cell membrane, Maximum are which of the following? Are which of the following? Is it going to be lipids or is it going to be proteins? Lipids or proteins? In terms of dry weight of the cell membrane, it is the proteins which are going to be more. Proteins constitute about 55% of the cell membrane. 55% of the cell membrane are going to be proteins. Right? So in terms of dry weight of most cell membranes, it's going to be proteins, which are about 55%. Of course, let's say, right, this is most cell membranes is 55%. Now, in most cell membranes, lipid protein ratio. What is the lipid protein ratio? What is the lipid protein ratio? Is it 1:1? Or is it 1:2? Or is it 1:3? Or is it 1:4? In most cell membranes, what is going to be the lipid protein ratio? If you're asked about the ratio, you must say 1:1. Right? You must say 1:1, even though proteins are higher than lipids, 55%. But the ratio is approximately 1:1. For 1:2 ratio, the proteins have to be double the amount of lipids. In that case, lipids have to be 33% and proteins have to be 66%. Right? But in most cell membranes, the lipid protein ratio would be 1:1. Next, let's have a look at the lipid protein ratio. Now, the next is, let's have a look at what are cell adhesion molecules. What are cell adhesion molecules? Cell adhesion molecules, right? Cell adhesion molecules, these are CANs. Cell adhesion molecules or CANs, these are cadherins, integrins, selectins, cadherins, integrins, selectins. Oligodendrocyte, yes, carbohydrates are up to 5%. Carbohydrates are up to 5%. Okay? But I give you an option between lipids and proteins, which is more. So in that case, proteins are more. Okay, oligodendrocyte. So cell adhesion molecules, these are CANs, which are cadherins, integrins, selectins, and proteins belonging to the IgG superfamily of proteins. To the IgG superfamily. So cadherins, integrins, selectins, and proteins belonging to the IgG superfamily. These are your cell adhesion molecules. Now, now there are two types of two important junctions which I'm going to do with you over here. The first one is what are known as the tight junctions. Tight junctions. Yes, Parag, I told you most cell membranes it is proteins, but in neurons it is lipids are more. Yes. Now, tight junctions are formed of special proteins which are called occludins, claudins, and jams. Occludins, claudins, and jams. And what are jams? Jams are junctional adhesion molecules. These are junctional adhesion molecules. This is known as jams, right? Jams. Occludins, claudins, and jams. Tight junctions, now these are very specific. These are very specific, and the name itself tells you that these are tight junctions between cells. And where do you see tight junctions? The examples of tight junctions, these are between the endothelial cells. This is between the endothelial cells of cerebral capillaries. And these tight junctions between the endothelial cells of cerebral capillaries, this is what is responsible for the blood-brain barrier. And this has been asked as a question. Blood-brain barrier is formed by, is it by astrocytes or is it by these tight junctions between the cells? Please remember, the tight junctions between the endothelial cells of cerebral capillaries, this is responsible for what is known as the blood-brain barrier. Astrocytes will induce the formation of tight junctions, but it is the tight junctions which are responsible for the blood-brain barrier. Right? What is the role of the astrocytes? Astrocytes induce the formation of, tight junctions. Induce the formation of tight junctions, but the tight junctions are the actual ones which are responsible for the blood-brain barrier. Then you also find tight junctions between, this will be also, they are seen between the cells of PCT, cells of the collecting duct in the kidney, then between the intestinal epithelial cells, right? So these are your tight junctions which are going to be formed. Tight junctions, like I said, these are the areas where you see the tight junctions. Yes. Now let us see here. Let us take the example of intestinal epithelial cells. Let's see what happens in the case of the intestinal epithelial cells. Occludins, claudins, these are the proteins which are responsible for tight junctions. They are special proteins which are responsible for tight junctions. They're formed of these proteins. Now, in the intestinal epithelial cells, you have these microvilli, right? Microvilli are going to be seen. This is in the intestinal epithelial cells. Okay? So obviously this is the lumen here. Now, between the cells on the luminal side, you have these tight junctions. Right? Between the cells on the luminal side. Basically, I'm trying to tell you what are the tight junctions. Tight junctions are made of proteins called occludins, claudins, and gems. Where do you find these tight junctions? Some examples, and that is endothelial cells of cerebral capillaries, which is responsible for blood-brain barrier, also between the cells of PCT and the collecting duct, and between the intestinal epithelial cells. In the intestinal epithelial cells, towards the luminal side, you have these tight junctions. These are the tight junctions between the cells on the luminal side. These are the tight junctions which are present, and these form what is known as the zonula occludens. Zonula occludens, right? Zonula occludens, or the this is towards the luminal side. So what is the advantage of the zonula occludens? Advantage of the zonula occludens is that it does not allow a paracellular movement of substances. There is no paracellular movement of substances which can happen. That is what is the advantage of the tight junctions. They do not allow substances to pass between the cells. Then, towards the middle of the cells of the intestinal epithelial cells, as the zonula adherens. Zonula adherens. And zonula adherens is formed by proteins which are called desmosomes. And these desmosomes are associated with intermediate filaments. Yes? Desmosomes are associated with intermediate filaments. Intermediate filaments form the cytoskeleton, right? Intermediate filaments will form the cytoskeleton, right? And so desmosomes are associated with these intermediate filaments. Zonular adherens. Towards the basal side of the cell, the cells are attached to the basement membrane with the help of special proteins, which are now called hemidesmosomes. These are your hemidesmosomes. Hemidesmosomes will attach the cells. They attach the cells to the basement membrane. They attach the cells to the basement membrane. Right? So this is what an intestinal epithelial cells look like. Right? Towards the luminal side, you have these tight junctions which form the zonular occludens. Towards the middle of the cell, you have a zonular adherens. Zonular adherens are the desmosomes which are associated with intermediate filaments. Attaching the cells to the basement membrane are the hemidesmosomes. Right? Please remember, tight junctions are formed by proteins which are known as occludins, claudins, jams. Prashant Kumar, occludins, claudins, jams are proteins which are responsible for tight junctions. Okay? Towards the luminal side, zonular occludins formed by tight junctions. Tight junctions are formed of proteins called claudins, occludins. Jams. Zonular adherens. What is zonular adherens? It is a band. Right? It is seen towards the middle of the intestinal epithelial cells. This is formed by desmosomes. Desmosomes are associated with intermediate filaments. Cells on the basal side are attached to to the basement membrane with the help of the hemidesmosomes. Okay? Adherence, beta Mohit Seni, adherence means helping the cells to adhere to one another. Okay? Now, this is as far as your these different zones in the intestinal epithelial cells is concerned. Next, let's have a look at tight junctions are zonular occludens. Prasad Khorpade. Okay. Now, then you have another set of junctions which are called gap junctions. Right? Gap junctions. Now, what are these gap junctions? Now, gap junctions are, desmosomes are proteins by themselves. Desmosomes are proteins by themselves. Now, gap junctions are formed of proteins called connexins. Right? These are formed by proteins. Gap junctions are formed by proteins, right, called connexins. Now, each connexin has 6 subunits which are known as connexins. Each connexin has 6 subunits, which are known as connexins, which surround a central pore. Gap junctions are made of proteins called connexins. Each connexin has got 6 subunits, which are known as connexins. And these are the connexins here, and they surround a central pore. The central pore has a size of, if you look at the diameter of the connexin, this is 2 nanometers. The central pore here has a diameter of 0.3 to 0.8 nanometers. One second, I'm just getting so distracted by your questions. Please see this once again. Harshita, Cam, whatever, Sal, Smruti, please understand this. Zonular occludence is formed by tight junctions. Tight junctions are formed of proteins called occludins, claudins, jams. Tight junctions do not allow a paracellular movement of substances. That means no substances can pass through the cells. Number 2, zonular adherence. This means, zonular occludence means it is not allowing passage of substances. Zonular adherence. Zonular means a band. Adherence means helps the cells to adhere. Proteins which are responsible for zonular adherence is desmosomes. Desmosomes are associated with intermediate filaments which are a part of the cytoskeleton. Basal side, you have hemidesmosomes which attach the cell to the basement membrane. Zonular occludence formed by tight junctions formed by proteins such as occludins, claudins, jams. Zonular adherence formed by desmosomes. Hemidesmosomes attach the cells to the basement membrane. Okay? All right. Oh God, Shilpa, these are not, tight junctions are only responsible for zonular occludence. This must be the 10th time that I've repeated it. Gap junctions formed by connexins. Each connexin has got 6 subunits, which are known as connexins, and these connexins will surround a central pore. The connexin of one cell is aligned with the connexin of a neighboring cell. Connexin of one cell is aligned with the connexin of a neighboring cell. So what happens is, these connexins will now form a gap junction, right? They will now form, these connexins are in line with each other. So what happens is, these allow a bidirectional transport of substances, right? They will allow a bidirectional movement of substances. These two connexins, they are aligned with each other and they will allow a bidirectional transport of substances, right? Bidirectional movement of substances. These gap junctions, they will allow a bidirectional transport of substances between the cells, right? This forms what is known as a gap junction. So gap junction are formed of connexins, and these are formed of connexins, and they allow a bidirectional transport of substances up to 1,000 daltons. Up to 1,000 daltons can move from one cell to the other, right? This is also what is known as an electrical synapse. And this question has been asked on the NEET exam. Electrical synapses are formed by tight junctions, gap junctions. Your answer is gap junctions. Gap junctions will form the electrical synapses. The next important point, gap junctions, they reduce the intercellular distance. They reduce the intercellular distance from 20 nanometers to 3 nanometers. Normal intercellular distance is 20, but wherever the gap junctions are present, it reduces to 3 nanometers. Intercellular distance means distance between the cells. Connections of two cells will be aligned with each other and they form the electrical synapse. And remember, through an electrical synapse, bidirectional movement is possible. They decrease the intercellular distance. A connexin mutation, it gives rise to a X-linked disorder. It gives rise to an X-linked disorder, which is known as the Charcot-Marie-Tooth disease. Charcot-Marie-Tooth disease. Yes, this is as far as your connexin mutation is concerned, right? It will give rise to a X. This is an X-linked disorder, which is called. This has a number of cardiac abnormalities. Yes. This is arrhythmias, Charcot-Marie-Tooth disease, right? So these gap junctions are formed by connexins. Connexin of one cell is aligned with connexin of neighboring cell. This results in what is known as the electrical synapse. Where do you find the gap junctions? Gap junctions are present in the cardiac cells, heart, between cardiac cells. Then it is also present in, like I said, that is why connexin mutation will give rise to a then this is also present in the retina, also in the single unit type of smooth muscle. Single unit type of smooth muscle, which is present in the GI tract. So these are the areas where you see the cardiac cells, right? In the heart, in the retina, in the single unit type of smooth muscle, which is present in the GI tract. And a connexin mutation, like I said, gives rise to a condition which is called Charcot-Marie-Tooth disease, which is an X-linked disorder, right? Just change this, please. The diameter of the central pore is 0.8 to 1.4 nanometers in size, not 0.3 to 0.8, please, 0.8 to 1.4. Okay? All right. This is as far as your, now have a look at this question here. 0.8 to 1.4. Please change that. Diameter of the central pore, which has been asked as a NEET question, this is 0.8 to 1.4. Diameter of the connexin is 2 nanometers. Central pore diameter is 0.8 to 1.4 nanometers. They decrease the intercellular distance from a normal of 20 nanometers to 3 nanometers. Where do you find these gap junctions? Cardiac cells, retina, and in the single unit type of smooth muscle. Now, one little diagram here, one little picture that I wanted you to see, and that is, this is what a gap junction looks like, right? These are your, they reduce the intercellular distance. Normal is 20 nanometers. Wherever the gap junctions are present, it is reduced to 3 nanometers. And like I said, connexin of one cell aligned with the connexin of a neighboring cell, resulting in a gap junction, right? So this is, again, please, so we've done all these different types of, we've done the cell adhesion molecules. The cell adhesion molecules, they help the cells to adhere to one another. Cadherins, integrins, selectins, these are more sort of general molecules. Specific one for tight junctions, occludins, claudins, jams. For gap junctions, connexins formed by connexins, which surround the central pore. Diameter of the central pore 0.8 to 1.4. Yes, and this is, like I said, gap junctions are formed in. Okay. Yes, we are going in for a lunch break. The ones who want to go for a lunch break, please do so. Now tell me, what questions do you want? Anybody with a specific question, please? 1.1, because proteins, see, it cannot be, the proteins are almost the same as lipids, more than lipids, but slightly more than lipids, right? So it has to be 1:1. For lipid protein ratio has to be 1. For 1:2, that means proteins have to be double. That is not the case. So best answer is 1:1. Okay? Osmol concept. Yes, I'll just show it to you. All right. The osmol concept, whoever wanted this is 1 osmol is 1 mole divided by the number of freely moving particles liberated in solution. This is 1 osmol is equal to 1 mole. But I've asked you that 1 mole will be equal to how many osmoles? Reverse. In that case, you have to see the number of freely moving particles. So number of osmoles will be equal to number of freely moving particles. Break is till 2 p.m. Break is till 2 p.m. Dy diagram in diabetes mellitus, not really. You don't have any loss or addition of fluid. That is, unless it's ketoacidosis, isn't it? Then it may be, then there is probably a dehydration which is seen. I just can't. There are too many of you typing at the same time. I just can't follow. Can you please revise the what is it? I just can't. It's too. There are too many of you typing at the same time. I don't know what to do. Okay. So difficult to do this.